Welcome to PAME's first webinar of 2022. I'm Allison Kukla, the Senior Manager for Programs and Partnerships at the Epilepsy Foundation. I'm also on PAME's Governance Committee and a person living with epilepsy. As I said, we're excited to have all of you joining us today to kick off our webinar series of the year, and specifically here to learn about SuDEP biomarkers. How close are we? These biomarkers could help identify individuals with an increased risk of SuDEP, which is a critical step to accurately counseling patients and families. Our moderator is a leading SuDEP researcher, Orrin Devinsky, so it's my honor to introduce him to you all here today. Orrin is a professor of neurology, neuroscience, neurosurgery, and psychiatry at the NYU School of Medicine. His epilepsy research includes translational therapies, SuDEP, healthful behavioral changes, autism, therapeutic electrical stimulation, quality of life, and cognitive and behavioral issues. He is the principal investigator for the North American SuDEP Registry and for the SUDC Registry and Research Collaborative. Other interests include behavioral neurology, evolutionary biology, nutrition, and history of science. Thanks for moderating today, Orrin, and I'm happy to hand it over to you now.
Thanks so much, Allison. It's a pleasure to be here, and an even greater pleasure to have two of my colleagues and friends here from very wide areas of the world. Shobi Sivathamboo is with us from the University of Melbourne in Australia, and Matthias Koepp is here from the University College London, Queen Square Hospital, the UK's leading neurology center. And the topic for today is biomarkers for SuDEP. And I think for many people, it's been apparent that one of the major obstacles to progress in helping prevent and understand SuDEP is having markers for it. And the reason they're so important, and you're going to hear about two different broad categories of biomarkers that are actively being investigated in a few moments. But the reason is that in most epilepsy programs who see relatively difficult to control patients, the rate of SuDEP is perhaps 1, maybe 1.5 per thousand per year. And the challenge with that is twofold. Number one, it's a low number, which is great, but when it happens, and at big epilepsy centers, it happens multiple times per year, it's a horrific tragedy. It's, someone who's been in this area for a long time, I get a call at 2 p.m. or 7 p.m. from a medical examiner, and my heart drops. Some 15-year-old, some 30-year-old that I've cared for 2 years or 10 years, I'm going to find out that they're no longer with us, and I can't predict it. And even worse, if we wanted to do trials and do something like give people a watch that could detect seizures and alarm a family member, or something to detect movement and sleep to alert somebody, to realistically do those studies and get data that can show we can help reduce the rate of SuDEP, we would need to give these to tens of thousands of people and follow them for years. So one reason we need biomarkers is so we can identify high-risk people who may be at 5 or 6 cases per thousand per year, or to put that in more English terms, 5 or 6% per decade. And if you're a 20-year-old with epilepsy, and if you have a 5% chance of dying from SuDEP over the next decade, that's horrible risk. The question is, how do we identify those people? And that's going to be the topic of today, because those biomarkers can help us plan studies to prevent SuDEP. They can also help us counsel patients who are at the highest risk, as well as those who are at the lowest risk, for how to better safeguard themselves, and for others that the risk is really low. So let's start the discussion. And the first speaker is Shobi Sivathamboo. As I said, she's from the University of Melbourne. It's been my pleasure to collaborate with her on several projects. And she'll be looking at some of the electrophysiological, EKG, and EEG potential biomarkers for SuDEP. Shobi?
Thank you, Dr. Dubinsky, for that very kind introduction. It is a pleasure to be your colleague and for the amazing work that you do for SuDEP. So this part of the talk will focus on emerging physiological biomarkers for SuDEP. So the objectives of today's talk are to review data on PGES and SuDEP risk, so post-ictal generalized EEG suppression, which is an EEG marker, as well as review data on ECG data and SuDEP risk, and go through summary and some of our future directions. So before I get started, I'd like to start with the Mortimer study, which is really a landmark study that has shaped our knowledge of mechanisms leading to SuDEP. And this beautiful study characterized the final mechanisms of cardiorespiratory dysfunction in SuDEP in the minutes leading to SuDEP. So this study has been really informative in planning for biomarkers and what we should be looking at. So before anything has even happened, all patients who subsequently died of SuDEP in a video EEG monitoring unit had at least one focal onset tonic-clonic seizure in the preceding 12 hours. And we know that tonic-clonic seizures in some patients particularly can have prolonged cardiorespiratory dysfunction lasting some 5 to 6 hours in some cases. This is then followed by the terminal focal onset tonic-clonic seizures that starts the cascade of events that lead to SuDEP. So this is a pattern of hyperventilation, and hyperventilation or rapid breathing is a pretty normal physiological response in relation to the tonic-clonic seizure as well as metabolic acidosis. Followed by a pattern called post-ictal generalized EEG suppression, which I'll get into in a moment. And in some patients, they had transient bradycardia or asystole or central apnea. And then in all patients, there was terminal apnea, which drove terminal asystole, so respiratory driving cardiac arrest, leading to death in all of these patients. And these are tracings from this study, which shows rapid cardiorespiratory collapse within minutes, some as quickly as 2, some as, and the longest being 18 minutes in SuDEP cases. So I'm going to start with data on PGES and SuDEP risk. So post-ictal generalized EEG suppression is an abnormal EEG pattern that's typically seen after a tonic-clonic seizure. So we define it as the generalized absence of EEG activity greater than 10 microvolts in amplitude, allowing for the various artifacts that you would typically see in the post-ictal period, such as muscle, breathing, movement, and electrode artifacts. So this is an example of a patient who's just had a tonic-clonic seizure, and there's a period of suppression that is post-ictal EEG suppression. So it is an inconsistent post-ictal feature, meaning that in the same patient, you can have multiple seizures, some of which are associated with PGES and some of which aren't. So the risk factors for PGES are seizures occurring in sleep, which increase the risk of PGES, as well as delayed oxygen administration during the seizure. Certain periictal seizures can also be, posturing semiologies can also be increase the risk of PGES duration, hypoxemia, apnea, as well as the presence of post-ictal posturing. But what we don't know is whether there's a causal relationship between PGES and post-ictal autonomic and cardiorespiratory dysfunction. PGES may merely be a marker of severe hypoxemia or seizure severity, or both. This is work from our video EEG monitoring unit at the Royal Melbourne Hospital, which looked at patients with convulsive seizures with and without PGES. So this shows in red the patients with PGES, and above in blue showing those without. The top row shows the median, minimum, and maximum heart rates, and the bottom row shows the same, but the respiratory rate. And as you can see with the respiratory rate, even before the seizure has started, patients with PGES already have lower respiratory rates. And then post-ictally, they aren't able to achieve the same threshold as those with without PGES, suggesting there may be some abnormal compensatory mechanisms in these patients. So this is more beautiful work done by Dr. Diehl, which shows that post-ictal EEG suppression can be associated with respiratory dysfunction. So this is one of the cases of PGES, followed by an apnea of 6 seconds long and associated desaturation. In this study, they found that one patient who subsequently died of SuDEP, as well as 2 new SuDEPs, also had postictal essential apnea. This is also a really important study by Dr. Nightscales, which was from our video EEG monitoring unit, which showed a patient who had 2 back-to-back tonic-clonic seizures. After the first tonic-clonic seizure, this patient developed postictal atrial fibrillation, and then had a subsequent tonic-clonic seizure within minutes. And then this patient had almost over 12 hours of postictal atrial fibrillation, which the patient reverted back to sinus rhythm after that time with cardiology input and medication use. Unfortunately, about 2 years later, after his monitoring unit, he subsequently died of a probable SuDEP. It's unlikely in itself that postictal AF can cause death in these patients, but this might be a biomarker of underlying autonomic dysfunction that increases the risk of SuDEP. So whether PGES is a marker of increased SuDEP risk is currently unknown. So it's definitely a leading candidate, where in all published cases of SuDEP, including Mortimer's, all cases were preceded by postictal generalized EEG suppression. Several small single center studies have examined the risk between PGES and SuDEP risk, but they've largely been heterogeneous. So beautiful work from Dr. Latu shows that in 10 patients who died of SuDEP and 30 matched controls, the PGES of 50 seconds or more was associated with increased SuDEP risk. And this paper nicely showed that a dose-dependent relationship with PGES duration. As the duration increased, the risk of SuDEP also increased. A larger study from the UK, however, could not replicate these results, where the presence or duration did not differ between cases and controls. So it's unclear at the moment whether PGES is an independent marker of SuDEP, but there's a lot of rationale to study it, such as in our biomarker study, which I'll go into a bit later. So moving on now to ECG and SuDEP risk. So a leading candidate is heart rate variability, which is a widely used measure of autonomic cardiac control. It's derived by studying the variations you see in adjacent heartbeat intervals, and it can be calculated from many different time domain and spectral components, which each give us information about different branches of the cardiac autonomic control. We do know that decreased heart rate variability is associated with many chronic cardiovascular disease states and premature mortality, such as after a myocardial infarction or chronic heart failure. This is important work showing that sudden cardiac death was significantly and independently associated with a marker of heart rate variability known as low frequency power. So in this study, they found that those with depressed low frequency power were far more likely to die from a sudden cardiac death than those with preserved low frequency power. So it begs the question, is heart rate variability altered in SuDEP? And there have been a number of investigations that have looked into it, mostly very small case series or select populations have been studied or single center. This is a case report from Dr. Jefferson, which really nicely shows the time course change of heart rate variability. So in the red, there's high frequency power, which strongly couples to parasympathetic activity, which slows down heart rate. So this actually increased in the lead up to SuDEP, which suggests that potentially vagal overactivity can be a potential mechanism for SuDEP. This is another recent study that examined response to hyperventilation in SuDEP cases and matched controls. So they assessed how heart rate changed at the end of hyperventilation and then 4 minutes following the end of hyperventilation. And they found that that change was blunted in those with SuDEP cases, which was predictive of SuDEP with an area under the curve of 0.87. And then coming to our study, which is preliminary work from our larger study, which looked at 31 SuDEP cases from 9 tertiary centers across the US, Australia, and Europe, which demonstrated that during wakefulness, we found low frequency power was depressed in the SuDEP group compared to the matched epilepsy controls, which is similar to what you see in patients with sudden cardiac death. We then adjusted for all different confounders that may affect heart rate variability that were identified from previous studies, and we found that low frequency power was still predictive in this model. We then looked at whether these variables have any relationship with the latency to SuDEP. So we found that normalized low frequency power in wakefulness was associated with a longer latency to SuDEP. So the higher this is, the longer to SuDEP. Whereas conversely, to put it in other terms, each 1% incremental reduction to low frequency power was associated with a reduction in latency, so the time to SuDEP decreased. We also found a positive correlation in sleep between time to SuDEP and normalized high frequency power, suggesting that this might have a cardioprotective role, and this is something that you see in patients who have survived myocardial infarction. We then looked at whether these findings could be predictive of patients who died of SuDEP, and we found that normalized low frequency power in wakefulness predicted the latency to SuDEP with a C statistic of 0.66. When we added high frequency power to this model, the predictive value became 0.7. So that's quite promising in itself. So going to my summary as well as future directions. So interictal physiological changes in EEG and ECG may be potential biomarkers of SuDEP risk, but we do need to validate these in larger multi-center studies that are really adequately powered to assess SuDEP risk. Integration of these biomarkers from these studies into multimodal prediction algorithms with known demographic and clinical risk factors may improve the model accuracy of SuDEP prediction. These are highly promising because these ECG and EEG are relatively inexpensive. They're accessible to most epilepsy settings, and they're non-invasive. ECG in particular is promising because it can be integrated into wearables to potentially facilitate real-time interventions for SuDEP prevention. So I'd like to end with work from Dr. Jha. This is really impressive work that shows a multimodal prediction algorithm. So there are 10 patients here, and each of the demographic and clinical data from these patients have been inputted into this model to show an absolute risk of SuDEP, which differs in all of these patients. So patient J has a much higher risk of SuDEP than patient A. And we are currently conducting a very large case control study, the largest of its kind, from 86 centers worldwide from 4 continents, that will look at ECG, EEG, as well as imaging biomarkers for SuDEP. So as we learn more about these biomarkers and we have validated biomarkers, we hope to integrate this with established risk factors, clinical and demographic, to produce these multimodal prediction algorithms that can stratify individual SuDEP risk and make SuDEP prevention trials more feasible. So I'd like to thank all of my collaborators and mentors, particularly Orrin, Terry, Dan, and Juliana. Thank you.
Great. Thank you, Shobi. And I think we'll hold questions until the next speaker, Matthias Koepp, has presented his material. And Matthias, as I said, is from University College London. The last time I saw Matthias was actually in Melbourne, Australia. So it's good that Shobi's bringing us back together. And Matthias has many areas of research expertise as an epileptologist, but imaging is one of his great strengths together with cognitive functions. And he will be talking to us about imaging biomarkers of SuDEP. So my pleasure to introduce Dr. Koepp from University College London.
Thank you very much, Orrin. Thank you very much for the opportunity to really to discuss the imaging data on SuDEP. I must confess that I have not contributed much to this field. So I see my presentation here very much more as a critical review. Oops, these are my disclosures. Really starting with the main question which is driving us. Are we there yet? Do we have biomarkers? What are they important for? They are important to measure severity, the risk of an event, of SuDEP, of the fatal event. Unless you can't, if you can't measure it, you cannot manage it. You need to measure something in order to improve it or to reduce the chances, and that's what biomarkers are for. And we don't have very good biomarkers, neither for epilepsy nor for SuDEP. Probably nothing else but seizures. Generalized tonic-clonic seizure frequency is probably the best risk factor for SuDEP. But this study here by Marco shows how. Can you see this? The pointer. Yeah, shows how unreliable recording of seizures is, probably even for generalized, not as bad for generalized tonic-clonic seizures. As this, so we are after some physiological measures, which can then serve as either prognostic, diagnostic, or predictive biomarkers. And for imaging, they should be quantifiable, objectively measured and evaluated, reproducible, cheap, and easy to obtain, with results available quickly, with high accuracy, good sensitivity, and good specificity. Clearly an oxymoron. Another health warning, really stating the obvious, that for imaging, what I'm presenting are almost exclusively correlations. And correlations do not imply causation, as here the excellent correlation between the divorce rate in Maine and per capita consumption of margarine in the US. It's less, or it's more obvious that there are confounding variables between the relationship between sale of ice cream and bushfires. Here, the confounding factor is clearly the heat or the summertime. But this is where the problem lies in related to imaging, that we measure MRI atrophy and assume this to be related or mechanistically causal related to SuDEP, but it might just be the consequence of a very common confounder, namely frequent generalized tonic-clonic seizures or frequency of seizures. What needs to be emphasized here at this point is that whilst it would be nice to have biomarkers for SuDEP, which are also explanatory or mechanistic biomarkers, that does not necessarily have to be the case. So when we're talking about a biomarker for SuDEP, then these are prognostic biomarkers, and they're slightly different from a mechanistic or diagnostic biomarker. So really, Susana Muller was the first to study SuDEP in human ex post in vivo using MRI. In this first MRI study, she found volume losses in the mesencephalon in focal epilepsy that were more severe and extended into the lower brainstem in patients with severe epilepsy, and most severe in 2 patients who later on died of SuDEP. In a follow-up study, she then correlated the loss in volume in brainstem with a physiological parameter, which we just heard from Shobi, which is relevant for the pathophysiology of SuDEP, namely heart rate variability. And so what she showed was that there was a particular correlation with reduced heart rate variability in these areas, periaqueductal gray, in various areas along the brainstem. Patients who had died of SuDEP had more widespread volume loss in their last MRI exam before death. So here, more extensive damage correlated with a shorter survival time since the MRI. So the combined regions here down there, encompassing autonomic, nucleus roughi, nuclei explains most of the variation at the time of SuDEP. So these observations suggest that focal epilepsy associated here with mesencephalic damage impairs autonomic control, and through this increases the risk of SuDEP if it expands into the medulla and affects nuclei involved in autonomic control. So these preliminary findings indicate that it might be actually possible to detect evidence of this potentially fatal progression of epilepsy associated with brain stem damage in MRIs acquired for clinical purpose years before SuDEP. But really, one needs to be careful about the spatial resolution, particularly the accuracy of these volumetric studies, particularly in brainstem areas. Maria Tom, our neuropathologist, who has a particular interest in SuDEP, correlated specimens from diseased patients, brainstem specimens from postmortem studies, and performed high resolution 9.5 Tesla MRI scans on these subjects, on these specimens, and compared these with various markers for myelin and for neuronal counts, and examined particularly the medullary volumes and the neural composition and the reticular formation zone. As these localize with regions containing respiratory regulatory nuclei, this could represent C-related alterations as SuDEP vulnerability factors and potential disease markers. What we found was a lower relative reticular formation zone volumes in the rostral medulla and higher actual volumes in the caudal medulla, so changes along the rostrocaudal dimensions, but no difference between groups for any of the quantitative MRI values in any of those regions. The strength of volumetric studies is really the assessment of cortical gray matter volumes. And in this study here, led by my colleague Berti Diehl, whose work I'm primarily present today, and the study is undertaken by our fellow Britta Wandschneider. We looked at MRIs of patients who had died from SuDEP later on following acquisition of the MRIs, and defined two control groups, a high-risk group matched to our SuDEP cases and stratified according to the accepted risk criteria of frequent generalized tonic-clonic seizures and nocturnal seizures, versus a low-risk group of people who did not have generalized tonic-clonic seizures and not nocturnal seizures, and were matched for other criteria. What Britta found was in the cohort of people who later died from SuDEP were increased gray matter in the right hippocampus and in the right parahippogyrus. An unusual finding to report increases. Normally we are used to decreases. So here, subjects at high, not only at SuDEP, but also at high risk of SuDEP showed increases in the right hippocampus, and this was independent on whether they had right or left temporal lobe epilepsy. This effect was more pronounced along these lines, and findings were very much similar across the whole sample, more bilateral. So subjects at high risk without identified pathology on clinical structure scan showed an increase of gray matter volume in both anterior hippocampus and amygdalae when compared to controls. In the case of gray matter volume increases, the relationship here is independent of markers of severe epilepsy, such as frequent convulsive seizures. So in a follow-up study, Beate's group showed that enhanced volume increases were in areas which trigger autonomic dysregulation, hypotension, and impede respiratory patterning. And particularly, they identified an area here, which they termed the entorhinal cortex, but it is actually further anterior to the entorhinal cortex. On review, I would call this piriform cortex. So this is part here of the temporal piriform cortex and the frontal piriform cortex, which is a particular interesting study, as could show recently. This part of the piriform cortex probably is representative of what's known in the animal in the preclinical area, in the preclinical research as area tempestus. Recently, we could show that removal of this area, which is part of the olfactory cortex, its central hub, an accelerator of information highly connected to the limbic and amygdala mesiotemporal region. Removal of this area is very much predicted of seizure outcome. Decreases, as I said, are more commonly seen in patients. And here for SuDEP cases, there were those seen in those at high risk of SuDEP in the left pulvinar of the thalamus compared to healthy controls. So in summary, these increased right hippocampal and parahippocampal gray matter volume changes and the gray matter volume decline in the posterior thalamus appear to be related to an overall SuDEP risk. The volume increases are potentially of dynamic origin, and they may result from they are related to the duration of the illness and probably result from repetitive injury related with severe epilepsy or repetitive seizure, while the thalamic declines probably are the result of excitotoxic or androgen injury sources. The thalamic injury may lead to an inability to recover breathing, to a hypoxic challenge from apnea, while the hippocampal, parahippocampal pathology may contribute to asymmetric influences on autonomic outflow, establishing circumstances for cardiac arrhythmia and hypotension. These structural changes may well be useful biomarkers to assist in the determination of the pathophysiology of SuDEP. So in this context may well be also mechanistic biomarkers, not just prognostic biomarkers. Metabolic changes were assessed by Beate's group using FDG PET. Here, these were FDG PETs acquired routinely as part of pre-epilepsy surgery assessments, and patients were stratified according to the accepted SuDEP risk criteria, again, seizure frequency and nocturnal seizures. And what she observed was an increased FDG uptake within the left putamen, the bilateral pallidum, bilateral thalamus, bilateral ventral diencephalon, and left claustrum. And all this may reflect a pathological disturbance that, again, contributes to disrupted autonomic functions, i.e. profound hypertension, altered sympathetic or parasympathetic drive to the heart, and so placing patients at risk for SuDEP. The basal ganglia patterns are particular concern because of their significant role in autonomic control and especially blood pressure maintenance. The increases or changes, so these were primarily increases seen in the basal ganglia, whereas decreases in particular were seen in the frontal lobe, and they correlated with the frequency of generalized tonic-clonic seizures. And the likely explanation here for this is can be found in very similar patterns seen in seminal work by Blumenfeld, who looked at blood flow changes and divided them into changes before the seizures, usually predominantly in the temporal lobe, as these were the majority of the focal onset seizures, then changes during the generalization phase with significant increases occurring in the bilateral superior cerebellum, and decreases in blue occurring in bilateral frontal association cortex. And then post-ictally, and this is when SuDEP occurs after the seizures, there are significant increases occur in the bilateral cerebellum, midbrain, ipsilateral, basal ganglia, and adjacent white matter, while decreases occur more in the bilateral frontal association cortex, more pronounced contralaterally. Which leads to suggestions of altered connectivity between cortical and subcortical, autonomic and breathing related sites, and two different patterns, a reduced functional connectivity. A pattern was identified by Beatrice's group, showing a disruption of the thalamic brain functional connectivity as shown here in high-risk SuDEP patients, particularly concerning, again, in view of the respiratory failure in SuDEP here, the thalamus relays extensive information to and from cortical to subcortical brain areas. And we know the importance of the importance of the thalamus. There is increased functional connectivity, primarily with an enhanced subnet network in high-risk SuDEP patients with enhanced connectivity patterns presented by connections from the frontal, medial, or orbitofrontal cortex to the insular and limbic cortex. So let me summarize what has been shown: altered networking among autonomic and breathing-related brain areas in those at high risk of SuDEP. The observed volumetric changes in SuDEP cases may be related to the presence of generalized tonic-clonic seizures or epilepsy duration. This is difficult to entangle and has to be the subject of future research, which also should combine the various imaging modalities with physiological, pharmacological, or behavioral challenge studies. And here I'm going to present my last slide, some blue sky research, which happens on the backbone of the COVID pandemic, that our pathologists were facing increased backlogs of high RSO producing procedures like postmortem, so that we stepped in with postmortem MRI and acquired images in people with sudden death for the imager exquisite pathology. I think nobody ever has seen an MRI of the heart like this. It doesn't beat. So this patient died from SuDEP, and this data is only recently was acquired. It is currently further examined. So let me conclude with a quote by Gabriel Garcia Marquez in relation to how close are we with biomarkers of SuDEP. Is it science fiction? Fiction was invented the day Jonas arrived home and told his wife that he was 3 days late because he had been swallowed by a whale. And this is my son, who came very close to a humpback whale when we were swimming near Tonga a few years ago, not far from Melbourne. Thank you very much for your attention.
Great. Thank you, Matthias. And looks like your son is on his way to becoming a scientist. So I would like to just, maybe introduce a cautionary and, optimistic note at the same time, and for both Shobi and Matthias to comment on. One of my passions in the last decade has been nutrition, as Allison mentioned. And, I can tell you a fable of a molecule called cholesterol. In 1950, a scientist named John Goffman, who was involved in World War II in isolating plutonium and uranium for the nuclear program successfully, he was also a physician, went to Berkeley and had gained access to the only ultracentrifuge in the United States. And he quickly spun down and found that he could isolate cholesterol. He later, in the 1950s, also found that he could fractionate cholesterol into high density and low density forms that we now know as good and bad cholesterol. By the end of the decade, he felt that his research had been hijacked by bad people, scientists who really wanted to make a splash and say that they knew that eating fats first and then saturated fats later elevated total cholesterol, and total cholesterol clogged arteries, and clogged arteries caused heart attacks and killed people. And when the Framingham Heart Study in 1961 indeed found that cholesterol levels of over 260 in men primarily could be associated with heart disease, and that was the study that gave us the word risk factors, including hypertension, smoking, things like that for heart disease, which are all true. And elevated cholesterol is indeed a risk factor for heart disease, especially before age 50, and especially when the levels are quite high. But he argued that carbohydrates actually elevated triglycerides and lowered HDL, which might be more important for heart disease. Now, the result, unfortunately, is that the American Heart Association, the NIH, the CDC, the Surgeon General, they went with the group that codified high cholesterol. And since LDL is the main fraction of cholesterol, the total LDL was evil. And I say this because those studies had hundreds of thousands of people aggregated now with millions of patient years of experience. And unfortunately, they did much more harm than good. I think they led to the expansion of sugar use, which is doubled or tripled. The diabetes rate, when Goffman published his 1960 warning, was 1% in the country. It's now well over 10%. Obesity rates were 7-8%. Now they're 36%. And so, given we're dealing with tiny numbers, which I think both Shobi and Matthias pointed out, there's the law of small numbers of Kahneman and Tversky, is that when you look at small groups, you can find things that are significant, but they don't get replicated in larger groups. And I'm a believer that biomarkers are needed. I think to advance this field, we need biomarkers. But I would just ask both Shobi and Matthias separately, given what's happened with cholesterol, and that not only did we not help people, but I would argue we did far more harm than good. And also low cholesterol levels are associated with higher rates of cancer. Never advertised, but if your cholesterol is under 160, you have high rates of cancer, high rates of suicide, and higher rates of traumatic death across multiple prospective, observational, and randomized studies. But that doesn't get out. So when we think about SuDEP and the limitations of the groups, how do we get around those potential pitfalls of biomarkers?
I think you've touched on some really critical points that have also informed us designing our own studies. And I think the last thing we want to do is put data out there as validated biomarkers when we haven't really got into that yet. And that's why we've designed a large case control study that's properly powered to assess those variables. But we certainly don't want, everyone going out and buying an Apple Watch because heart rate variability might predict, SuDEP. we certainly have to be cautious and validate these preliminary findings, which show a lot of potential before we can make any clear conclusions from that data. Matthias?
I love this story of the cholesterol, or I can't agree more. And I wonder sometimes whether in SuDEP research in particular we miss a trick. So I'm looking after patients in this epilepsy center, and they're the worst of the worst in terms of seizure frequency. They're still alive. So they have thousands of seizures, and they're well documented. And they're alive. So their mechanisms in terms of SuDEP prevention must be super strong. So I wonder whether we are looking at the wrong side of the coin and then we are trapped in this very small numbers, which at the end, it's just one seizure out of many, which leads to SuDEP. So why we're probably better off by looking at the opposite. What makes the seizure stop, but does not stop the heart and the breathing? So that's just a thought outside the box here, really.
No, I think it's a good point, Matthias. David Marsden, who's at University College London as a movement disorders. I remember as a medical student in Boston, and he spoke to the Boston Neurology Society, and number one, he was so ill. He just spoke off his head in full paragraphs and topic sentences. It was crazy. But he made a point, and I think what you said, reversing the question is sometimes very helpful. Like, why is it that some people have 2,000 tonic-clonic convulsive seizures and they just keep going like the ever-ready bat, they're fine. Yeah. And other people have their first or second or fourth ones and they don't survive. I think it would be worth looking at the resilience of those as lessons, or have to be there for us. So let me pose some questions from the audience that have come up, and either of you feel free. Are there any products for children to help lower the risk of SuDEP? And I think maybe to broaden that, in fairness for adults and children, if you are a patient, an adult with epilepsy, if you're a parent of a child or a young adult with epilepsy, what would you counsel your patients as preventive measures?
Well, never sleep alone. It's probably your best preventative measure.
I think that's right. How about other sleep hygiene, adherence with medications, avoiding alcohol? Yeah. And again, I think the challenge for us as clinicians is, for children, it's a different situation, but when, young adults go to college, they're going to be surrounded by peers who may come, even if they're, teetotalers and saints, which they rarely are because they're surrounded by this all the time, but their roommate or the person even in the next room, if they have a single, can come home intoxicated at 2 a.m., play loud music, disrupt their sleep. And it's a really hard environment at that age too. And I do think that's a point in life where there's a lot of danger. And when people go out in careers, investment banking, medicine, a lot of sleep deprivation early in professional life as well. And we accept that as a society. It's often needed, but I think avoiding that would be good. But Shobi, would you have any thoughts for child specifically, a mattress monitor, a watch that identifies movement or electrodermal response? Any thoughts you would counsel parents?
I think there are a lot of emerging interventions, like you mentioned, watches, Empatica, which can detect nocturnal tonic-clonic seizures in particular quite accurately, which is also FDA approved. There are anti-suffocation pillows, and there are more cutting-edge therapies like the use of SSRIs or caffeine, which can potentially reverse respiratory depression, or it can make it less severe. But again, these are all emerging therapies. And then there's still the problem of what do we actually do when there's no rest, and how do we respond to that? So a lot of those questions are still yet to be determined. We know from the Mortimer study that the near SuDEPs are the ones that received CPR rapidly within 3 minutes of the seizure termination. So I think to facilitate those kind of interventions, there's still a lot of work that needs to be done that can save lives.
Okay, there are a couple other questions that are related, and I can touch on some. My apologies. The doctor mentioned the Apple Watch. I've been looking into the Embrace 2 for my son. For his seizures, they occur in sleep, and I discovered that my son had epilepsy because he stopped breathing and had to perform CPR before the ambulance arrived. So again, the Embrace may or may not pick that up. Certainly one thing that some parents do, and I think it's a reasonably wise decision, is if you can get an oxygen monitor that will stay on, if you could attach something to the child's toe, for example, and would alarm you. Because ultimately, as both our speakers mentioned, the final common pathway is often a convulsive seizure that leads to a lack of breathing, that leads to lower oxygen, higher carbon dioxide, and eventually death. So if you can early on pick up a lack of oxygen, the oxygen saturation goes from 95 to 100% down to 80% or lower, you've got a problem, and getting alarmed for that can probably be very, very helpful. And someone had asked, how does sleeping with someone, Matthias said it kind of tongue-in-cheek, but I think he was being very serious, actually. Many studies have shown that individuals who have a bed partner or a monitor that may be a developmentally disabled adult in a residential facility where counselors come by very routinely and observe them and listen to the sound in their room. Essentially, if someone has a seizure and it turns them over and they're face down in the bedding, the pillow, the sheets, and their brain turns off after a seizure, rolling them on their side, freeing their airway, their nose and their mouth, and just gentle stimulation, Thomas, are you okay, is probably life-saving. And if they're alone and no one's nearby and they're in a bed by themselves and no one can hear the seizure and no one can attend to them, then unfortunately that individual, if it's a seizure with a more severe post-ictal EEG suppression, could be life-threatening or deadly. And here's a question, Matthias, for you. What causes volume loss in the brainstem? What do you think the mechanism is? And I'll add to that, what's the mechanism of increased volume in the right mesial temporal lobe?
So I think the increase is actually the more interesting question in a way, and that is use-dependent plasticity, I would think. Something really which, and it is striking that's on the right, where we know there are differences in autonomic vagal representation. The decreases, this is, I think that the changes in the brainstem volume has to be seen with a bit of a pinch of salt. These are tiny changes. So, but they seem to be also related to severity and duration of epilepsy. So that's probably a result of core injuries or pseudo-related atrophy. But I think the increases are more puzzling, and we've seen this, and in particular puzzle about this, the area where they happen. It's this kind of piriform anterior cortex, which is an amplifier. So if you get a lot of wrong signals and in this area, I would argue that this is use dependent.
Okay. A couple questions I'll answer quickly. Someone asked if nosebleeds are common with grand mal seizures. I would say no. I think they can occur. I think you can get conjunctival hemorrhages in the eye from increased pressure, but I think they can occur, but I would say they're uncommon. For many of us, including myself, in the wintertime, you're more predisposed to nosebleeds because there's more hot, dry, forced air, and the capillary bed in the bottom third of your nose tends to get friable, and people bleed. So one prevention for that is just a Q-tip with a little bit of Vaseline or Neosporin, anything like that. Don't go high up, just the bottom third. And it's remarkably good. If you can do it twice a day, you won't get nosebleeds. And someone asked if there's a difference, and maybe Shobi, you can take this, between patients who have a idiopathic or primary generalized seizure disorder versus a focal to secondarily generalized tonic-clonic seizure disorder. Are there differences for SuDEP risk between those two groups, and how well has it been studied?
I think a lot of our data is probably biased towards focal epilepsies because most patients are admitted for video EEG monitoring tend to be more focal epilepsies. What is emerging is that even recently, we're about to publish a paper on this. A patient with a generalized epilepsy actually had episodes of ventricular tachycardia associated with tonic-clonic seizures. So I think that this group is quite understudied in some respect, but the mechanisms for SuDEP risk may be different to the classic Mortimer centrally mediated cardiorespiratory collapse that we see.
Right. And I'll just add, from the North American SuDEP registry, which is not a systematic, it's just referrals from medical examiners, from the community like Epilepsy Foundation and others. We actually had a fair number of generalized epilepsy cases. And I think the rule is that the focal epilepsy cases tend to be more treatment resistant to medication. So we think of generalized epilepsies as those that respond well to medication overall. The problem is that patients may just forget 1 or 2 doses of medication, or be sleep deprived, or drink, or have a cold and take too much of a decongestant or Benadryl, and have a single breakthrough tonic-clonic seizure. But when they break through, they tend to have the tonic-clonics, whereas when the focals break through, they tend to have focal aware or unaware seizures, which tend not to be associated with SuDEP. So in general, it's the tonic-clonic. So I think we do worry more about the focal patients who are more treatment resistant and are on a lot of meds, but the generalized are unfortunately by no means out of the risk category. And someone asked, I know this literature, but I haven't seen this, but had mentioned the pediatric literature, having a monitor does not decrease the incidence of SIDS. Does monitoring in the case of epilepsy prevent SuDEP? I don't think we've answered the SuDEP question. I'm not sure how well the SIDS question was studied and what those monitors were, but I wonder if either of Matthias or Shobi know any more about the SIDS literature.
I find the SIDS literature when we did our original study and found the increases. So here coming back to the increases, super fascinating. And I wonder whether again we're missing a trick here by really combining efforts with the SIDS community, with the cardiac death community. Because in SIDS, they find increased hippocampus volumes. And this has been shown that this is actually limited to, or there's a kind of one pathology study has shown that it's a double layer in the dentate gyrus. So their increases that's seen on volumes in SIDS. So there is pathologically probably some similarities are happening here. I think I wonder, and I'm not very, these are apnea matrices, which are basically picking up non-movement, and I think they are less sensitive to movement matrices. So that's probably explains why there haven't been that these monitors are not being effective. But ultimately, again, I think and I've been arguing with the VNS. There's an interesting question here about the VNS neuromodulation, and so they, particularly the new VNS, actually does some cardiac monitoring. So they should be able to send out alarms ultimately when the heart stops beating or becomes slower, and it doesn't do this. So there are actually lots of things we could do and improve with the available tools. You don't even need the sophisticated heart rate variability monitoring. You just, there
are a number of questions that popped up in the chat as well. And I know we're kind of towards the end, but we can maybe stay 5 more minutes and go through a few. I'll try to bullet them in a couple and then ask the panelists a few. One asked, are there studies regarding various genetic mutations which cause epilepsy, such as SYNGAP1, and whether they're more or less likely to cause SuDEP? And I have an interest in this area, and I think we know Dravet syndrome with SCN1A mutations are fairly high risk for SuDEP. Hopefully better medications will reduce that over time. And certainly it can occur in any of the epileptic encephalopathies, whether it's CDKL5 or SYNGAP1 or FOXG1. but I don't believe they've been well studied. I think there's at least 1 or 2 publications on duplication 15q, which are also at high risk. But I would say in my experiences, the more difficult to control seizures and the more convulsive seizures, the higher the risk, regardless of what the genetic or non-genetic cause is. Another mom, mom asked, my son's autistic and has epilepsy, not aware how he can communicate his feelings of a seizure. So monitors are of keen interest. And I think, yeah, for anyone like that, a lot of nonverbal individuals do have epilepsy, and monitoring them can be done. I think, as the speakers had mentioned, sleep is a really critical time. So if you're going to focus your attention on monitoring, whether it's even, as I say to some parents, how can you keep a watch on? You could literally wait for the child or young adult to fall asleep and then just gently put an Embrace Simpatica or a similar Apple Watch around their wrist, and take it off when they wake up. So there's ways to do that. In addition, I think there's a great comment by David Auerbach, who is a scientist in this area. When developing predictive biomarkers, should we put greater faith in those that are the most statistically significant versus markers that are linked to mechanism? It's a great question. I'm not sure, Matthias or Shobi, if you have an answer. Yeah,
I agree.
Yeah.
I think we are driven. We are blinded by significance question rather than relevance.
And another one from a scientist, Berti Diehl, connectivity of brain networks has been pointed out as a significant risk factor for SuDEP. Should we try to get more done through non-invasive measures such as EEG for network markers?
Really, the health warning for all the connectivity measures right now, they are group findings and they're not relevant for the individual subject. So there, I think the EEG is more promising.
I know it's a great area of future research, but I don't think we're there yet. And then another one from a mom: have detailed studies been done on ECG morphology in epilepsy patients and correlated with PGES? Does interictal activity? If we're proactively collecting this relatively inexpensive data, would we better understand the resilient patients relative to those at risk? Any thoughts, Shobi? You've done research on this.
So this is data that we're collecting as part of our biomarker study. So we're collecting a routine 2-lead ECG done as part of video EEG monitoring, as well as a 12-lead ECG, which will provide more data on the morphology in itself to look at. There are certain morphologies that have found to be associated with increased SuDEP risk, but largely in small numbers. So we really need to look at this in a larger sample size.
Okay, and Dr. Feingold asked, what about the use of respiratory changes as a biomarker for SuDEP? I wish we had better ones in the epilepsy monitoring unit on all our patients, but be curious, Matthias or Shobi, what do you think?
Absolutely. This is something I'm presently engaged in, trying to implement a routine respiratory protocol at our hospital, but I think it is sometimes met with resistance, and people don't actually understand how much respiration is affected by seizures and how early monitoring of respiration can identify the patients at risk that then progress to cardiac arrhythmias. So you can call a Met call and things, or code blue, much earlier in such patients. And I really do wish we had better data. There are some institutions that do have some of this comprehensive respiratory data, but very few.
Right. And one 30-year-old woman asked that she's fortunately been seizure-free, at least for major convulsions, for 5 years, but her medication, levetiracetam, sounds like it causes side effects. And, she just asked, what's the best option? And I think it's a case where, listen, unfortunately, not everyone with epilepsy can be controlled. Some people are controlled with side effects, but levetiracetam is certainly a good medication, but it does cause significant side effects for some people. And there are very good alternatives, especially for focal epilepsy, that may work at least as well and be better tolerated. So I would suggest for people like this 30-year-old woman that they consult with their epilepsy physician and think about possibility of changing to another med, which could be done conservatively and minimize the risk of a seizure, and then hopefully make a transition. And someone asked, what do you think the role of education is in preventing SuDEP? I lost my 23-year-old son and had never been told anything. And this is unfortunately an incredibly common story. Even today, I think many of us here have been involved with SuDEP awareness education research for more than a decade. And we still get people when they call to the SuDEP registry that had never heard about SuDEP for their son or their husband or wife or brother. And I think we all, things like what we're doing here right now is fantastic, and we have to get the word out to the broader epilepsy community. Because I do think education, we have seen a lowering of SuDEP rates in the United States across at least 3 broad geographic areas, at least by 30% over like 6 years. And I do think awareness is part of it. People know that, they need to take their meds, they need to get good sleep, they should avoid alcohol. And I think people understand there are real consequences. Whereas, one young man before he went to college, and I told him he had to be good for all these reasons. And he said, what does it matter? So I forget my meds and I have a big seizure. It's happened to me before and I'm a little out of it for a few hours and then I'm fine. And, his mother was there. I told him, you could die from a seizure. And the mother started crying. He calmed his mom down. He went to college, and 2 months later, he went on a drinking binge, forgot his meds, and he died from SuDEP. So even education doesn't always work. And that age group is a hard group. We were all there once. And many of us didn't do everything our parents wished we had done at that point in our life. And I think one final question. I think there are more, and I think the organizers, Allison and Anne, maybe you can send some of the questions. We're happy to, I'm sure Matthias and Shobi, myself, will be happy to reach out. Are there any heart testing, such as a Holter monitor, suggested for high-risk patients for SuDEP or patients with drug-resistant epilepsy? Do you think there's a role in getting Holter EKG testing?
So in my experience with patients who have died of SuDEP, typically their routine ECG investigations are normal. So it's probably not the most helpful. Potentially implantable cardiac monitors may be helpful, but we haven't really gotten to that yet. We found a high incidence of undetected, potentially serious cardiac arrhythmias using an implantable loop recorder, which is monitored for years, which probably detects a higher frequency than a standard 24-hour Holter. But again, we don't know which patients would benefit most from this sort of invasive procedure. So we're not really there yet to recommend that sort of stuff.
Okay, well, I want to thank the Epilepsy Foundation, Alison Kukla and Anne Gramiak, as well as our wonderful speakers today, Shobi Sivathamboo and Matthias Koepp, for participating in this. I think we've gotten an incredible response of questions and interest, and hopefully this will propel us all to learn more, to do more, and prevent more. Thank you all very much.